How do testicular cancer types guide treatment decisions? Testicular cancer is not one-size-fits-all. Understanding the types of testicular cancer is crucial for guiding treatment decisions. The two main categories are seminomas and nonseminomas. Each type behaves differently and responds to treatments in unique ways. Seminomas are generally slower-growing tumors. They are highly sensitive to radiation and chemotherapy, which means they often have a good prognosis. Pure seminomas do not contain teratomatous elements, which are resistant to chemotherapy. This makes treatment more straightforward. On the other hand, nonseminomas are a bit more complex. This group includes several types like embryonal carcinoma, yolk sac tumor, choriocarcinoma, teratoma, and mixed germ cell tumors. Nonseminomas tend to be more aggressive. They can spread earlier and often requiring a combination of surgery and chemotherapy. The presence of teratomatous elements in nonseminomas makes surgery a critical part of treatment, as these elements do not respond well to chemotherapy. When it comes to treatment choices, surgery is typically the first step. The primary procedure is called radical inguinal orchiectomy, which involves removing the affected testicle and spermatic cord. For nonseminomas, surgery is especially important due to the chemotherapy-resistant components. Testis-sparing surgery is rare and usually reserved for very small tumors or cases with bilateral disease. Radiation therapy is mainly used for seminomas because they respond well to it. In contrast, nonseminomas do not usually requiring radiation. Chemotherapy is a common treatment for both types, but the regimens differ. Seminomas respond well to platinum-based chemotherapy. Nonseminomas often need more aggressive chemotherapy due to their higher risk of spreading and recurrence. Surveillance is another option for some patients. Active surveillance involves regular imaging and monitoring of tumor markers. This approach is often suitable for early-stage seminomas and certain low-risk nonseminomas. However, nonseminomas with specific risk factors may requiring additional therapy to prevent relapse. Staging also plays a significant role in treatment decisions. Stage 0, or carcinoma in situ, may be monitored or treated with surgery or radiation if there is a high risk of progression. Stage I indicates that the tumor is confined to the testicle, and treatment may involve orchiectomy followed by surveillance or adjuvant therapy. Stages Roman II and triple indicate that the cancer has spread to lymph nodes or other parts of the body, necessitating chemotherapy and sometimes surgery. Risk-adapted therapy is becoming more personalized, especially for nonseminomas. Treatment plans are tailored based on individual risk factors like lymphovascular invasion and tumor histology. For seminomas, while risk-adapted therapy is less established, surveillance is common in early stages. Finally, clinical trials are exploring new treatments and combinations to improve outcomes and reduce side effects. Patients may want to consider participating in these trials based on their specific tumor type and stage. In summary, the type of testicular cancer significantly influences treatment decisions. Understanding whether a tumor is a seminoma or nonseminoma helps determine the best approach for surgery, radiation, chemotherapy, and surveillance. This tailored approach aims to maximize the chances of a cure while minimizing the side effects of treatment. Always consult with healthcare professionals to develop a personalized treatment plan that considers individual circumstances and preferences.